From the JAMA Network, this is JAMA Oncology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Oncology.
Hi, my name is Nora Disis, and I'm the editor of JAMA Oncology and a deputy editor at JAMA. Welcome to today's podcast, where we'll be talking to Dr. Pablo Leone from the Dana-Farber Cancer Center about his paper, Mortality Risks Over 20 Years in Men with Stage 1 to 3 Hormone Receptor Positive Breast Cancer. Welcome, Dr. Leone, and thank you for taking the time to talk to us about this important topic.
Thank you very much for having me, Dr. Disis.
My first question is, how common is breast cancer in men, and what subtype of breast cancer are men most likely to develop?
So, breast cancer in men is overall uncommon. In the United States, for example, of all breast cancer diagnoses, of all new breast cancer diagnoses, approximately 1% of them occur in men, and approximately 99% occur in women. And in terms of the subtypes of breast cancer, most men develop hormone receptor positive breast cancer. So approximately 85% of men with breast cancer have hormone receptor positive HER2 negative breast cancer, and approximately 12% of men have hormone receptor positive HER2 negative breast cancer. So in all, hormone receptor positive breast cancer is at least 95% or greater of all breast cancers that occur in men.
Now, you've done a lot of research looking at how breast cancer is different between men and women in terms of stage and age at diagnosis and lots of other things. What are the main differences, and what are some of the findings over the years?
So there are differences in between men and women with breast cancer. One of the most notable differences is that the female population in the United States and in the world undergoes screening for breast cancer, whereas the male population does not. And as such, in general, men with breast cancer tend to present with more advanced stages than women. However, those differences are not as large, fortunately, as one may anticipate, given the differences in the screening for both populations. For example, the incidence of stage 4 breast cancer in men is approximately 8% in the United States, whereas in women is approximately 5%. In terms of other differences, age is another difference, as you mentioned. Most men with breast cancer in the United States are diagnosed at the age of 67 years old. In other words, the median age at diagnosis is approximately 67 years old. And in women, it's younger. It's approximately 60 years old. And there are some other differences as well. So one of them is the histologic type of breast cancer. Most men are diagnosed with ductal histologies, and that's also the case for women, but other histologies are much more uncommon in men than in women. For example, lobular histologies are very uncommon in men. And then there are differences, as we were mentioning earlier, in the distribution of tumor subtypes, where most men have hormone receptor positive breast cancer, which is also true for women, but the rate of cases with hormone receptor positive breast cancer in men is much higher than it is in women.
I also was impressed, as an aside, by the finding that the majority of men get mastectomies to treat their cancer, which is very different from the surgeries used to treat women. Why is that?
That is a very good question. I think it has several reasons. One is because, in general, the tumor size at diagnosis tends to be bigger in men than in women because of the lack of screening that we were mentioning earlier. And sometimes that finding, along with the fact that the breast volume is different between men and women, makes the need for mastectomy more common in men. And I think that's one of the factors that influence the decision of undergoing mastectomy. Another one is the tumor location in men. So most breast cancers in men are centrally located, basically either very close to the areola or right behind the areola. And the central location sometimes is also a factor to determine the role for mastectomy. And lastly, I think the lack of solid evidence in the appropriate local-regional management specific for male breast cancer has led potentially, I suspect, to some treatment decisions being made by the historic habit of doing mastectomies for breast cancer, as opposed to adopting more recent types of surgery, such as lumpectomies.
That's very interesting. You know, this is one of the first studies to evaluate very long-term survival and factors associated with late mortality in men with breast cancer. Can you tell us about the design of this study and some of the major findings that you were reporting in this manuscript?
Yes, so this was a study that we did. It's an observational cohort study that we did using data from the SEER database from the National Cancer Institute, where we included men who were diagnosed with either stage 1 or 2 or 3 breast cancer that was hormone receptor positive. And in the study, we aimed to look at 20-year risks of breast cancer-specific mortality and non-breast cancer-specific mortality, or also referred to as other causes of death that are not breast cancer. And in order to look at late mortality, what we did is that we included men who were diagnosed between 1990 and 2008 to have sufficient follow-up. So in terms of the major findings, we found that breast cancer in men that is hormone receptor positive has a long-term risk of mortality from breast cancer for at least 20 years, if not longer, and that risk depends on traditional clinical pathologic factors that are present from initial diagnosis, such as the age of the patient, the tumor size, the grade, the nodal status. And another thing that we found that was interesting is that although the risk of long-term mortality is high, it does depend by stage, and particularly the balance between the risk of death from breast cancer as compared with the risk of dying from other causes that are not breast cancer. For example, in stage 1 breast cancer, the risk of dying from breast cancer is 4 times lower than the risk of dying from other causes. For stage 2, that risk is approximately half the risk of dying from breast cancer as compared to dying from other causes. And for stage 3, the risk appears similarly high, both for the risk of dying from breast cancer as well as the risk of dying from other causes, at approximately 45% each. And the last finding that we think is interesting is that the kinetics of the risk, or in other words, the distribution of the instantaneous risk of mortality from breast cancer in men, appears to have a bimodal distribution, particularly at higher stages, with an early peak and a late peak.
And why do you think there is this bimodal distribution? Because that is not seen in women. Do you know why that is seen in men?
I think when comparing long-term risks, both men and women have high risk of breast cancer-specific mortality for hormone receptor positive breast cancer. But in looking at that distribution, women tend to have one peak that occurs at approximately 5 or 6 years, and then the risk declines thereafter. And it declines somewhat in a linear way, continuously. Whereas in men, there is a similar peak early on that appears in our study. It was shown to be at around 4 years from initial diagnosis. But then there is a second peak that occurs at 11 and 12 years that is even higher than the first one. And the question is, why is that the case? There could be the possibility that it is due to endocrine therapy differences between men and women, but this appears unlikely in my opinion, because if it is due to endocrine therapy stopping at 5 years in men, as opposed to women, for example, we would not expect to see a reduction in the risk in between the 4 and the 11 years. Instead, we think that there may be other factors associated with this finding. One could be differences in tumor biology between men and women. Another could be differences in tumor dormancy or cell senescence in between men and women with breast cancer. But there could also be host factors, such as tumor microenvironment differences or host immune differences between men and women as well.
You brought up a question about endocrine therapy stopping or not stopping. One of the limitations of the SEER database, which you used for this study, is that there's very limited data on the systemic therapies that the patients have received. Are there differences between the way men and women with breast cancer are treated?
Well, so I think that the differences in endocrine therapy, in terms of the differences in treatment in general, endocrine therapy is possibly the area where the largest difference exists. So in general, the guideline of duration of endocrine therapy is similar for both men and women with breast cancer, with at least 5 years of endocrine therapy and the possibility of extending endocrine therapy for longer. But the options for endocrine therapy are different. So the main standard endocrine therapy option for men with breast cancer is tamoxifen, and has been tamoxifen since the beginning of tamoxifen. In women, in contrast, we have abandoned the use of tamoxifen over the decades to incorporate the use of other agents such as aromatase inhibitors in postmenopausal women, and more recently in premenopausal women, to consider, in some cases, the use of ovarian suppression with an aromatase inhibitor or tamoxifen. So in men, we don't generally recommend using aromatase inhibitors for the treatment of breast cancer. And this has to do with the fact that there is very limited evidence in the efficacy of aromatase inhibitors for the treatment of male breast cancer. And our group, in collaboration with the TBCRC cooperative group, is doing a clinical trial called ETHAN to try to understand the comparative efficacy of different endocrine therapies, including tamoxifen and aromatase inhibitors, to see whether aromatase inhibitors may be an effective treatment option for men, and also to try to understand the additional value of adding gonadal suppression in men, as has been seen in the benefit of treating women with breast cancer, and premenopausal women with breast cancer. Other differences in treatment, we were talking a little bit earlier about the differences in surgery. And then the other main treatment option, I think, is systemic chemotherapy, in which there are not major differences between men and women in terms of the agents or the doses that we use, but sometimes the patient selection can be different because of the risk profile of different patients. So, for example, certain men may have higher risk for cardiac disease, in which case the use of anthracyclines may be less preferred, for example. So there may be differences in patient selection between men and women with breast cancer with regards to the use of chemotherapy.
So in summary, Pablo, if you were a practicing clinician seeing patients with breast cancer, what are your major take-homes about male breast cancer from this paper?
The main take-home message is that the risk of breast cancer mortality persists in hormone receptor positive breast cancer in men as it does in women, and it does depend on the usual traditional clinical pathologic factors, although the kinetics of that risk appears to be somewhat different between men and women. And I think our study underlines the need for better adjuvant therapies, for that matter, not only for men and also for women, to address the high risk that patients face over such a prolonged period of time.
Well, thank you very much for joining us today, Dr. Leone, and thank you for continuing such important work about this issue of breast cancer in men. Thank you, listeners, for joining us on today's podcast. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.